Process of digesting it. I have the pleasure and fortune to be moderating this afternoon's session 2, Medical Cannabis Across Life Stages, Optimizing Care for PTSD, Women's Health, and Aging Populations. So we're going to try to get back on schedule. Our first speaker is Dr. Mitchell Doucette. He's a Ph.D. and Senior Research Director at Leafwell, and he's going to tell us about the impact of medical cannabis on healthcare utilization in the PTSD patients. This is a retrospective cohort study. Dr. Doucette, I'm very excited to hear your data, and the floor is yours.
Okay. Well, thank you all of you who are here. I understand that they're probably still doing lunch stuff upstairs, but at the same time, I appreciate all of you being here. Okay, so my name is Mitch Doucette. I'm the Senior Research Director at Leafwell. Again, I'm a trained epidemiologist / statistician. So again, I'll try to keep us awake as best as possible here. And I do want to say that, again, if you'd like to read a little bit more about the presentation, this is a preprint. So this is available as a PDF. It's not peer-reviewed, although it is being peer-reviewed at this point, but you may look at it at any time. I want to disclose that this study was conducted using data provided by Leafwell. Leafwell is a telehealth company. Leafwell does not manufacture or sell cannabis products, and the author declares that there's no direct financial interest in the production or sale of cannabis products. Okay. Today, I'm going to take you through a 4-part story on the impact of medical cannabis on PTSD. First, in the problems section, I'll explore why PTSD drives high rates of utilization and why we need to understand whether the efficacious results that we see in a lot of other studies, and including this one, actually translates into downstream health effects. And the methods I'll describe are retrospective cohort design using telehealth registry data and our causal inference approach. In the results, I'll share our key findings on medical cannabis's impact on healthcare utilization and quality. And again, we'll discuss the safety profile of the exposure, which of course is very important. I'll walk through some model checks and sensitivity analyses. And finally, we'll talk about some implications and some future clinical directions. All right, in 2020, approximately 13 million Americans were living with post-traumatic stress disorder, or PTSD. And throughout their lifetime, about 6 out of every 100 Americans are diagnosed with PTSD, with women being more likely than men to receive this diagnosis. Now, again, research suggests that a new PTSD diagnosis represents a total medical cost increase of about $6,000, adjusted for 2024 dollars. And part of that increase in total medical costs is attributable to individuals with PTSD often exhibiting a higher frequency of healthcare utilization visits. Again, multiple studies show that PTSD patients use healthcare at rates 30 to 50% higher than the general population. Another contributing factor to these increases is the healthcare use, again, related to comorbid conditions. So again, PTSD patients have a lot of other health problems related to their condition, and specifically, PTSD patients are at elevated risk for developing chronic musculoskeletal pain within the first year of their trauma. Many, again, PTSD patients suffer from persistent pain, often stemming from this traumatic injury. This heightens both the physical and psychological distress and creates a cycle of increased healthcare demand. And part of this healthcare demand involves prescription opioids, as we've, again, heard today, as rates of both PTSD and opioid use disorder have increased in the past decades. These patterns impose substantial strain on healthcare systems, and again, and patients, and they underscore the need for therapies that can reduce these system exacerbations and the associated acute visits. I'm going to skip over this a little bit because we've heard a lot about the endocannabinoid system today, but very basically, there is a biomechanical, again, rationale for why medical cannabis does impact and have positive effects for individuals with PTSD. And it has everything to do with the CB1 receptors. Again, happy to talk more about that, but I think we've heard a lot about the receptors and how the endocannabinoid system interacts with pain for today. But medical cannabis is now legal in 38 states and Washington, D.C., with the majority of states including PTSD as a qualifying condition. To this end, There has been an uptick in what we refer to as real-world evidence suggesting that medical cannabis is associated with things like increased sleep quality, reduced flashbacks, and again, improved quality of life among PTSD patients. However, missing from this evidence is long-term downstream examinations of whether medical cannabis is associated with lower healthcare utilization rates. Right, being able to show that medical cannabis utilization has positive downstream effects actually would strengthen its case for efficacy. Right? If we see a bunch of studies that say medical cannabis is great for PTSD and the quality of life increases, again, these are all good things. But a lot of that is self-reported and not something that comes from, again, something from a medical system or a healthcare system where we're looking at actual interactions. If we can show that there's a decrease in again, healthcare utilization, it's a lot of evidence that the efficacy that we find for quality of life is not just associated with those self-reported measures, but tangible reductions in healthcare expenditures. All right, to that end, we sought to estimate what's referred to in statistical terms as the average treatment effect, which is, again, just a fancy way of saying the overall kind of effect of medical cannabis use on quality of life and healthcare utilization, again, specifically among PTSD patients. So, when we're designing these types of trials and different studies, we need to break it down into two kind of categories, right? What is our outcome? What are we measuring? And then, again, what is the exposure, right? Exposure here is cannabis versus not cannabis. But I'll start here with the outcome. So again, Leafwell, again, is a telehealth company whose data has been used in medical cannabis patients previously. You know, we've published over 7 peer-reviewed manuscripts in the past 2 years. And as part of this process, when they become patients, we ask them to provide and fill out a pretty extensive intake survey where they provide demographics and health status prior to seeing a provider. So we accessed this Leafwell database using their administrative data from June to September of 2024, highlighted here in gray. And we collected the online structured questionnaire for analysis. So for the study, the exposed group, again, was those who obtained a medical certification card, wow, that's a big one, back in 2023. So these are individuals who came and got a medical card certification in 2023, and then came back a year later in 2024, right? And from that, we can infer that most likely they used medical cannabis enough so that they came back to become recertified a year later. Now, the unexposed group were new medical cannabis card patients who self-reported being cannabis-naive for the past year. So in a sense, what we're doing is we're creating 2 groups, one that took cannabis for at least a year, and here we have those administrative records to kind of mostly confirm that. And then we have unexposed group here who are new and have told us that they've never used cannabis before. During the study period, the administrative data asked both the exposed and unexposed groups the same set of intake questions. So for outcomes, we were asked to recall the past 6 months and indicate whether they had been to urgent care, the emergency room, or been hospitalized. And we asked both groups to rate their quality of life in the past month, and here we express that as the number of unhealthy days. So again, if we go back just one slide, we again are understanding people who have used medical cannabis versus people who haven't, and we have some certainty that this exposed group, as we might think of them as, used for a year, again, because they've come back and recertified their card. We included those who were 18 and had a PTSD diagnosis. Again, for the new patients in the study, if they had used cannabis recreationally or for any reason in the past year, they were excluded from being in the unexposed group. And less than 2% of patients had missing data, again, because the intake form is very much required. And so this was something that, in statistical terms, you might have to consider if that was a lot higher, but in this case, we didn't necessarily need to do that, which is great. I'll also add here that we did have some external IRB oversight, which completed our review of our analysis. So we selected a lot of things we need to control for, right? In statistical terms, if we go back to statistics class, if you think, well, the question a lot of times becomes, well, well, what could actually explain some of the differences we might find, right? So we tried to identify a number of covariates that would explain away, in this case, if we didn't do it properly, some of the results that we'd find. So we looked at things like, again, alcohol use, tobacco use, whether or not they had health insurance, their sex, their race, ethnicity, and their age. And importantly, right, all of those things are in some way related to either using healthcare. For example, someone who, again, has really high tobacco use might use healthcare more often. Males, probably not surprisingly, use healthcare more often. But more importantly, we controlled for a lot of things that could really, really impact our analysis. So things like, does someone have severe PTSD or does someone have mild PTSD? Is someone's chronic pain very, very high or is it low, right? So we were able to, using validated scales, control for and get people who looked similar in order to make sure that the analysis we did was the best that we could do. Okay, now, I want you all to stay with me. I know we just had lunch, but I'm going to explain a little bit of the statistical methodologies that we used here. So the question sometimes becomes, why do we need something called causal inference, right? So causal inference is what we might think of as, does X cause Y, right? Answering that question can sometimes be really, really easy, right? It's really, really easy if you have 100 people and you flip a coin, and every time it's a heads, you go into control group, and every time you go tails, it goes in the treatment group, right? That's really easy to do because you've taken away, you've added chance to that, right? There's a randomization mechanism. But here, this is not random, right? These people who are selecting to become medical cannabis patients, or in this case, maybe have never used before. So, in observational studies, treatment and exposed groups often differ on key characteristics from control groups. And if we just simply compare all those different covariates I just mentioned, again, it would really conflate what we think of as the baseline differences with actual effects. So the model we used here was something called inverse probability weighting. That's just a fancy way of saying we take all those covariates, right? And again, we use a model to identify their probability of being exposed, and then we match people on that probability, right? So we take and we try to understand someone's likelihood, and then we identify matches who are going to look very similar on different characteristics. For all intents and purposes here, this method is something that's referred to as doubly robust. That means that if we screw up one part of the model, because maybe you say the model didn't perform well, there's a second part of the model that adds some sort of regression adjustment. And if that model is correct, then it doesn't matter if the first part was wrong, right? Even so, we still need to do different types of sensitivity analysis, which I'll go into. We conducted 2 sensitivity tests, all right? And really, even the most carefully chosen causal models rely on assumptions about, again, how treatment or exposure are related to patient characteristics. We tested a bunch of different ways of going at this, right? There's, I would say at least, maybe 5 to 10 defensible ways of going about doing this analysis. And, well, we can very easily do all 5 of those things. And if it tells us the same thing, we're really certain about that effect, right? If it's not just one and say maybe the rest of them are wrong, or not wrong, but say something different, then maybe we're a little bit more skeptical. Another type of test we can do is specific to the methodology, but what I'll say is it's essentially a way of, you can think of it as outliers, right? Every type of data set has an outlier, right? Someone whose age is 99, but the rest of the age median is 45, right? Another way of testing whether or not the statistical analysis you've done is correct is by taking out those outliers and seeing if it's the same, right? So we were able to do that too, and just take a quick look and see if the results were the same. I do want to just call out that we did not directly measure symptom progression as the survey was cross-sectional. For disease worsening was the need for urgent, emergent, or inpatient care in the past 6 months due to PTSD symptoms that were self-reported to patients. Okay, so what do we find here? Okay, I'm gonna ask you a couple hypothetical questions, or hyperbolic questions, and then answer them. Okay, whenever you're using a propensity score model, right, where we're trying to identify people who are very, very similar, so that way we're mimicking that randomization mechanism, right, for a randomized control trial. Obviously, we can't randomize people here, but we can get really close to being randomization, right? So in order to first do that, you need to ask the first question, which is, are the exposed and unexposed groups similar on their characteristics, right? So this tells us, on average, are the two groups very similar, right? In this study, we had 19,049 PTSD patients, which is a pretty sizable N. And there was 64 people in the exposed group and 35 people in the unexposed group. In red here, we see that this is something called a standardized mean difference. It's just a way of looking at the difference between the two variables from like proportion size here. But in red, we see that they're very different, right? There's more females and non-Hispanic whites in the exposed group. They're older, they're healthier too, which of course, right? If the exposed group is healthier, well, then there might be a better chance of us finding a positive result, right? So we want to make sure we're controlling and taking care of that. In green here, you see that the inverse probability weights based on the covariates actually have gone away now, right? So using some of our statistical models, we show that we've essentially created two groups that look really similar on average, right? And the average there is important. The second question you need to ask, right? There's two questions we need to ask. First is, on average, are they similar? Next question is, do you have enough people in each group to compare one person to the other, right? And in this case, what that is referring to is that outlier aspect I was talking about earlier, right? And we do see some outliers, right? We see some people who are a much higher probability of being exposed based on their characteristics, a much lower probability of being exposed. But we do see a healthy amount of people here in this, which used to be purple. I'm slightly colorblind, so I actually don't know what color this is. I don't know. Oops, sorry. But again, this isn't bad. This is something that we'd be pretty happy with. But again, we can take out these individuals, and I'll show that in a moment. We can take out some of these individuals and see, hey, do we have the same results, right? And if we do, then that tells us that we've probably correctly ran our models. All right, results. All four of our outcomes, right? So we looked at three types of healthcare utilizations, one kind of quality of life measure. All four of them went in the same direction, right? So in that terms, we think of it as like directionality. It's all going the same way. Now for hospitalizations, those weren't, and statistically significant, but the rest of them were. And there's probably reasons why that's probably true. But for urgent care and emergency room visits, as well as number of unhealthy days, which is, again, these are all validated measures, we see statistically significant declines. So we'll start with unhealthy days, right? So we see a 19% reduction relative to controls. So the exposed group had a 19% better or fewer number of unhealthy days compared to the control group. Importantly, the downstream effects, right? That 19% then translates to 35% reduction in urgent care and ED visits, right? So if we think of this as a continuum of effect, right, you can have increase in quality of life, which is great, but if that quality of life doesn't translate into change, then again, right, it's just one part of the puzzle, right? But here we're showing that change in quality of life actually translates into real world kind of, evidence in terms of change. Now, those sensitivity tests, right? So sure, you could take my word for it. I did all the right stuff. That's great. I don't have to show you all of this. But at the same time, right, we want to be really certain as epidemiologists, as statisticians, and again, as you all as clinicians, right? Okay, well, let's change a couple things and see what happens. Again, we used a number of different models. For the sake of time, I'm not going to get into the names of them, but essentially they're very similar to the first type of method, but very different. These models, again, just kind of tweak some of the assumptions. But very importantly, what do we see? We see that they're almost all the exact same, right? So hospitalizations, slight decline, but probably not statistically significant. Urgent care and emergency room, almost nearly the exact same. I think the lowest was 34 and the highest was 38 in terms of percent reduction. And then the number of unhealthy days, right? Almost the exact same as the prior. I'll go back just to show, right? And the scale's a little different. But, right, so what does this tell us? This tells us that all the models show a very similar average treatment effect, or that effect that I was referring to earlier, compared to the primary models. This is really good, right? This tells us, hey, you are probably onto something here. Next, we want to, again, go back to that kind of statistical tail that I was talking about, right? And we can take out some of those people who have really high scores, what we think of as propensity scores, or that probability of again, being exposed. We can take out those low and high individuals, and we can take out different percentages of them, and then we can see whether or not the results we had, if they remain the same, right? And again, what do we see? We see almost the exact same thing. And importantly, we actually see a strengthening of the effects, right? So if you take out those outliers, you see actually that as a higher percentage of the tolerance increases, so say we take out about 10% of the people, the strength of the reduction actually, again, increases, right? Which again, these are two indicators that what we did are actually probably a real world reflection of the results. Which again, that's what you want to see. You want to see that not just one time, but many times the same kinds of results. Okay, the important part of the story, though, is, well, was it safe and tolerable, right? It'd be one thing, right, if, there's a lot of adverse events and, maybe people had better quality of life and doing all these things, but maybe it was impacting them in a negative way, right? But that's not what we found. So in total, 19 of the 1,261 exposed group patients reported an adverse event. So that's only about 1.5%. So 1.5% of the people who used medical cannabis for a year and came back to become recertified, again, reported that they had something, an adverse event or a negative reaction related to their medical cannabis use. The most common was increased fatigue, appetite, and nausea. And we wanted to understand, okay, well, if you have an increase in fatigue or increase in nausea, that doesn't sound great, but how does that impact you? What is the impact on your daily life, right? So we asked them, rate on a scale of 0 to 10, what is that and how does that impact you on a daily basis? And I can say that the mean impact was 2.4, right? So 0 being no impact, 10 being a lot of impact. And we see that the majority of these were very minimally impacting individuals' lives, right? So, to recap, we see, again, I'll go back one slide. We see increased quality of life associated, again, and related to reductions in healthcare utilization. So these kind of things are very much related and gives us much more confidence that this medication that individuals are using or exposed to in this context is actually producing some sort of real-world effect, right? Importantly, though, we're also seeing that the negative harms of that are very minimal, and for those of which who have negative harms, the impact is quite tolerable, right? So those are all important pieces to the puzzle. So, I keep skipping, sorry. Our study suggests that among those with PTSD, medical cannabis patients had, again, lower acute healthcare utilization, improved quality of life compared to a group of cannabis-naive patients. This is a substantial finding. If we go back to how we started this, it's part of the same story. It's adding credence to a causal effect, or what we might think of as an efficacious effect of medical cannabis. By mitigating these symptoms, medical cannabis may reduce the likelihood of acute exacerbations and necessitate, and lower the need for urgent and emergent care. The interaction between PTSD and chronic pain may partly explain some of these decreases in healthcare utilization too, right? Chronic pain is prevalent among those with PTSD, and medical cannabis has been shown to have analgesic effects. By addressing both the psychological and potentially the physiological symptoms, medical cannabis may offer a more comprehensive therapeutic option than, again, some other therapeutic options that are currently, again, indicated from an FDA perspective. Now, the one caveat here is that our findings suggest that medical cannabis could be a valuable adjunctive therapy for PTSD with minimal side effects. When I say adjunctive, I mean something that isn't taking away. Because one of the assumptions of the study is that no one changed any of their, say, prescriptions or maybe psychotherapy utilization. Now, again, we don't know that, but we can assume that, and again, that may or may not be true. But under that assumption, what we're saying is simply adding medical cannabis isn't something that's taking away, but it also being beneficial. And again, we've actually published research in the journal Clinical Drug Investigation that does suggest that medical cannabis is a likely cost-effective adjunctive treatment for specifically PTSD. So that's also available to read at any time. Further research is needed to estimate these healthcare costs and savings associated with our findings, right? So I've had a number of conversations with individuals today. What's the one thing that always comes back to? How do we move people? We move people, unfortunately, right, like it or not, with money. And again, it's sometimes can be a controversial thing, but at the same time, there has been so many years of study looking at the efficacious use of medical cannabis for a number of conditions, yet that still hasn't moved the needle, right? If we all acknowledge that, well, what will move the needle, right? My argument is, if you can go to a health insurer, if you can go to the federal government, if you go to the VA and say, hey, simply giving access to this may save you X amount of dollars, right? And in this case, we can take those 35% reductions and we can translate that from an economic perspective into dollars, right? If we give them that information, that I think is very powerful. Now, again, I'm not saying that should be how it is, right? I'm not saying that that's the best way to do it, but it may be something that people would listen to, which again, I don't think is the best indicator of things. But again, I do think it's an important thing to point out here. We didn't find the hospitalizations changed, and I think that makes sense. This finding may be due to relatively low incidence of hospitalization in our sample close to 2,000 people. It may just be that not enough people went to the hospital for us to detect that, but again, that's okay. And we are planning to do the same study, but looking at a dose response. So looking at for people who use every day versus people who don't or use every other, different types of daily use habits, seeing if the results are the same. All right, I will end here by saying this study is not without limitations. The data is self-reported, which of course introduces lots of bias. Again, we didn't clinically observe the dosage, and without adherence data, we can't confirm these results from the temporality perspective that I referred to earlier. So the results may be reflective of people seeking medical cannabis with PTSD rather than the PTSD general population, which I think is a fair critique. And we didn't randomize anyone, although again, we did our best to try to get those populations that look the exact same. And we did pretty good, I think. While the use of our data from one single telehealth company does potentially limit the generalizability, again, this study used data from over 34 states, which may enhance some of the study's generalizability too. So a little push and pull there. Okay, but I would like to thank all of you for being here after lunch. And I hope we're a little bit more on track here. I want to thank the participants who participated in this research. At the end, happy to take any questions. And again, if you'd like, this is a QR code. You may read all of this as you're falling asleep at bedtime, because to be honest, that's what I do too sometimes. All right.
Excellent job. Thank you, Dr. Doucette. And again, I think we all need more data, so thank you for that compelling data on the positive effects on PTSD of medical cannabis and potentially leading to cost reductions in healthcare as well. Our next topic will be exploring the role of cannabis